Great, thank you. It's really a pleasure to be here and represent surgical oncology. My clinical practice is both melanoma and sarcoma. I run clinical trials. I also have a tumor immunology lab, so the immune system in melanoma is dear to my heart. So one of the things I just want to put out there, as we talk about the standard of care of sentinel lymph node biopsy today, there's a lot that's changing, right, with neoadjuvant therapy and all of that. And so I'm not going to get into that today. We're going to talk about standard of care, what we know, and where we're headed. I was one of the principal investigators at University of Michigan on the Merlin trial, and I also act as a consultant now that we have data and figure out how to use that data. So in general, what is the sentinel lymph node biopsy, since most of you don't actually do this? So we use typically two dyes, both a radioactive tracer and then a blue dye in the operating room where we inject the primary melanoma site. It gets taken up into the lymphatics, and it will drain into the primary drainage lymph nodes or sentinel lymph nodes, okay? So typically that's between 1 to 3 lymph nodes in a basin, but for our patients that have, let's say, a back melanoma, it could map to 4 locations, right? So when we talk to our patients about this, it's not just the primary site wide excision and the sentinel node site. It potentially could go to both axillas and both groins. I have patients like that. It happens, right? About 25% of the time. So you have to, make sure that you know what the morbidity and the risks of going into a sentinel node procedure, because they could step out of your OR with 5 incisions, okay? If it's on the arm or leg, not so much, but if you do this with 2 dyes, you successfully map 98% of the time when you use both dyes. And the risk of having a negative sentinel lymph node when you do both dyes is less than 5%. So it's actually a really great test to identify the correct sentinel lymph node, and then our pathologist then looks at it and tells if it's positive or negative. And overall, it pretty much is a low morbidity. So this is what it looks like in the operating room. We see that dye, we take that out, we try to stay very close to the lymph node so you're not cutting lymphatics you don't need to, so they don't get things like lymphedema of the extremity. And so current indications, you heard a little bit this, right? But based on NCCNs and guidelines, when you have a T1A that's low risk, right? We do not recommend doing that. That's a low risk. So we don't do GAP, we don't do anything, we don't recommend it. However, for those T1Bs that are 0.8 or more, or less than 0.8 with ulceration, we consider it. And also there's the subsets. They're not officially T1Bs, but the ones that, the young age, less than 42, greater than 2 mitosis, LVI, we consider. Those patients are referred to us and we discuss the risk and benefits of doing the sentinel lymph node because there could be a 5 to 10% risk, okay? Now we talk about this 5 to 10% risk, 5%, what is that based on? For every patient, I can tell you some patients have a 2% risk and they're like, cut me tomorrow and take out the node. And then I have patients that have a 10% risk and they're like, why would you ever consider doing that? That's so low, right? So you have to understand there's a lot of shared decision that we do with our patients when we talk about sentinel lymph nodes. Now, for the intermediate risk, we do recommend for accurate staging because it's estimated there's a greater than 10% risk. I am going to talk about long-term follow-up data from MSLT1, which is where patients were randomized to sentinel lymph node or observation and only to do a complete lymph node dissection for clinical disease, and everyone with a positive sentinel lymph node got a complete dissection. The now 10-year follow-up data shows that there might be a subset of those patients that the sentinel lymph node biopsy is curative, right? And they don't recur less. So we're going to talk about that. So there might be a group of patients that we might want to think about sentinel lymph node biopsy, not just for staging. And then thick melanomas, we stage them with sentinel lymph node, but we are definitely not potentially giving them benefit because they are so high risk anyway. Right? So I can tell you, I trained at Memorial Sloan Kettering Cancer Center, and out of all the surgical oncologists, there were some that would never do a sentinel biopsy for the thick melanomas, and the others that would. And that is a discussion, again, we have with our patient, because are we actually benefiting them? We know they already have a very high risk of distant disease. Overall, there is a low risk of complications, especially in your healthy patients, right? When you have that healthy patient who has no comorbidities, you take them to the operating room, they pretty much have, a low rate. Now, that seroma rate, it depends what you call seroma. Everyone is going to have some fluid under the incision. When you take out a sentinel lymph node, it goes away in 2 weeks. But overall, it is a low-risk procedure. And most of these complications are maybe if they have an infection, you give antibiotics for a few days, wound care. So there's no real long-term morbidities, and lymphedema is extremely low risk if you do a sentinel lymph node appropriately and stay very close to the lymph node, and you're a surgical oncologist trained doing this, not a general surgeon who does it 3 times a year. Okay, so reasons to do a sentinel node biopsy. 1, staging. You just saw this, right? So this is great. This is the best staging we have. You have your T stage and you have your end stage. And the 8th edition really improved prognostication. But of course, there's some constraints. But when you look at the sentinel lymph node negative population and you look at the overall survival, the 5 and 10-year survival, and you compare it to the negative and positive, you stratify the patients out significantly. So if you did not do a sentinel lymph node biopsy, right, so you don't know if it's negative or positive, you wouldn't be able to tell this difference, okay? So if you have a patient who has a clinical 2B, and you tell them that their 10-year survival is 82%, and you don't know about their sentinel lymph node, if it was positive, you bring that down to 60%. That's a big difference, right? So this is where sentinel lymph node biopsy helps you educate your patients and think about what their recurrence and survival is, right, relative to their melanoma. But not all stages are the same. So I'm just going to give you a few scenarios. We see these patients all the time, the 3As. We say, 3A patients, oh yeah, they're the best. They're the best 3s, right? These are the 1 millimeter melanomas that might have one small deposit of melanoma in their sentinel lymph node. So here's one example. But this is also a 3A. 1 millimeter has ulceration, 1 positive sentinel lymph node, 9 millimeter deposit though. But that's not in the staging system. I know that patient has a higher risk, right? Now patient 3, 2 millimeter, sentinel lymph node positive, 3 positive sentinel lymph nodes, still 3A, right? So we just know by looking at this, I know that these patients are not the same, but they're staged the same. So this is where maybe looking at the pathology of the node or maybe where gene expression could be helpful and complementary in the future. We just don't have the data yet. Now this is a very interesting study. This is 3,600 patients where they looked at the size of the sentinel lymph node deposit, right, the micrometastasis, and it's stratified out between less than 0.3 and greater than 0.3. They also looked at 1 millimeter, 2 millimeter. Once you get above 0.3, it doesn't make a difference. It stratifies like this, and there's a significant difference in 5-year and 10-year survival. So this is something we consider when we think about stage 3A patients. Okay, so now we're going to talk about may a sentinel lymph node improve survival? So the MSLT1 trial, so this is way back, right? 2006, right? Where we have the trial. And this is the first where we wanted to, when I say we, I wasn't doing it yet, but it was, do we even do a sentinel lymph node? What's the utility of it? And patients were randomized to sentinel lymph node. If it was positive, they got a complete dissection. Or we just watched the patients, and if they had a clinical node recurrence, then they got a dissection, okay? And what this showed, the early data, is that we were finding the same patients. We were identifying the same amount of patients that would have a clinical node develop with the sentinel lymph node biopsy. So we were identifying it earlier. So great, it works. No difference in melanoma-specific survival at the early report of this, and this established the role of sentinel lymph node biopsy. Well, in 2014, the long-term follow-up data was looked at, the melanoma-specific survival. And if you look at the patients who had a sentinel lymph node that was positive versus the patients who had node recurrence and underwent lymph node dissection at that point, remember, all of these patients got lymph node dissection, right, which we don't do today, you can see that there is a significant survival difference at 10 years. So, right, 41 versus 62 alive at 10 years. And so there is a difference there. And this is only for the intermediate thickness melanomas, which at the time was defined at 0.2 to 3.5. When you look at the same long-term follow-up data from thick melanomas, the greater than 3.5, there is no difference, okay? So again, saying that sentinel lymph node biopsy definitely doesn't have a utility in this setting, and there could be a potential role, right? The patients that may be doing that sentinel lymph node and picking it up early before it kind of got out of the node. We can talk about immune surveillance, but there is something here that I think we should consider. Okay. It also informs the method of surveillance. So when we have a patient who does a sentinel lymph node, we now know how to follow them. So MSLT2 was where patients who had a positive sentinel lymph node were randomized to either observation with ultrasound. So we do this every 4 months for 2 years. If it's still negative, then we do every 6 months for 3 to 5 years, versus patients got a complete nodal dissection. And the reason why this was done, this clinical trials, because as surgeons, we know that like 85% of our patients had lymph node dissections with negative nodes. We were taking out so many negative nodes that we're like, there has to be a better way. So is there equipoise in not taking out the nodes right away? And the best way to identify this is with ultrasound, right? If you have a good ultrasonographer and radiologist, we can pick up these subtle findings, rounding of nodes, different echogenicity of the lymph node, and we can identify changes before you see it on a CT scan or a PET scan. PET scans are negative, right, in this setting, but you can pick up this on ultrasound. In this trial, if there was a change, then it got biopsied, it was positive, then the patients had complete nodal dissection. And what we saw is that the node recurrence-free survival, of course, was different, right? We know 15% of patients do have positive disease there, right? And we identified that and then took them for dissection. But there was no difference in melanoma-specific survival. So now we're saving 85% of patients, right? And we're not taking them all to the operating room. So this was great. So now we can do that. However, if we didn't do the sentinel lymph node, we wouldn't be able to do those ultrasounds and pick them up, because we don't do it on the sentinel lymph node negative patients. So how would we know which patients to monitor if we didn't do a sentinel node? And all the trials that we're talking about, right, we're in the setting of doing a sentinel lymph node biopsy. And we're also going to think about, when we talk about adjuvant trials, and the next talk is going to really dive into that, all of those patients had a sentinel lymph node biopsy so we could, right, correctly stage them. And so if we're going to use that data to interpret how to treat our patients, right, it is a very important piece of data. I'm going to step back, though, and say, are we doing too many sentinel lymph nodes, okay? So 85% of patients that we do sentinel nodes have a negative, right? So now here we're going back to those numbers again. We're like, the majority of patients that we do sentinel lymph node, it's negative. So we accurately stage them, but, you know, is there a way that we could identify better which patients have the risk? And, you know, we use age, thickness, mitotic rate. You saw those nomograms. All of those help us kind of make decisions, but I can tell you it's really hard to know, and also to tell a patient that there may or may not be, you know, what's their specific risk. And I can tell you for a patient, it's 100%, right, if it's positive or negative. So these are long discussions we have. And then there's the patients that have the T1As. We talked about their very low risk. We don't do a sentinel node biopsy, but there are patients that have a higher than 5% risk, you know, and who are they, and how do we do it? And you heard about the gene expression. So we're trying to get data. We need the tools to be able to do that. I'm going to use a case example to now kind of talk about these nuances of adjuvant therapy and, you know, how we think about developing a way to think about patients, whether we should do sentinel node or not. This is one of my patients who came to me. She was 44. She originally had a 0.4 millimeter superficial spreading left shoulder. It wasn't ulcerated. There was 2 mitoses. She was treated at another hospital in the community. There was a deep margin on shave. They actually did microstaging. It came back at 0.5, and so she had a wide excision with 1 centimeter margins. At 18 months is when I met her. She noticed a palpable mass in her left axilla. It was metastatic melanoma. She came to see me. We scanned her. You can see she has a large node right there, and they actually put a clip in it thinking that maybe we could treat her. She had other staging, negative for any disease. So this is oligometastatic in her lymph node, stage 3, right? So resectable stage 3. And today, after we had S1801, standard of care is to have neoadjuvant immunotherapy before doing dissection. Surgeons did dissections for clinical nodal disease for decades, and we don't cure patients, right? With neoadjuvant therapy, we see better outcomes. However, she had an autoimmune condition, had chronic pericarditis, and the risk was just too high. So the medical oncologist said, you know what, I think we treat her surgically. She's young. We don't want to hurt her with her disease. So if we just think back to this, if we knew that she was the high risk stage 1, right, the 0.5, if we knew that, and, you know, at that time, if we did a sentinel lymph node biopsy, she would have been 3A. Her 5 and 10-year survival, right, is 93-80%. Adjuvant therapy is actually not recommended in this in NCCN guidelines. And, you know, could that have been a better outcome? If you think about the adjuvant trial here, pembrolizumab versus placebo, this is all stage 3 here. I'm sorry, no, I pulled out. This is just the 3A. There's no difference in survival in the early data. So this is the median follow-up, only 1.25 years. With longer follow-up, would this be better? We actually have that now. Now remember, if anyone recurred, they could cross over. And so here's the long-term follow-up data just came out in 2024. So if you look at the 3A, there's no difference, right? So adjuvant immunotherapy is not helping these 3A patients. For 3B and 3C, there looks like there could be improvement in recurrence-free survival, right? We're not talking about overall survival or melanoma-specific survival. We're talking about recurrence. And a lot of times we think we just delay recurrence sometimes in adjuvant therapy. But in any case, in 3A, she wouldn't be recommended this. And when we think about patients, if we don't do a sentinel node biopsy and they recur, you know, everyone's like, well, maybe we can just give adjuvant therapy. Well, you know, there's a lot of risks. You know, a lot of young women become infertile. They have other issues, autoimmune conditions, and all patients will get, you know, some kind of side effects, but not all of them get the benefit. And so when we think about patients, we have to really think about the risk and benefits, and I think we have to be careful about altering our standard of care without the evidence showing that that is safe to do. When we look at the NCCN guidelines for stage 3, in terms of adjuvant therapy, with the patients with very low tumor volume, stage 3A, right? The toxicity outweighs the benefits, so it's not recommended. But they did add that study I showed you. So if you have a 0.3 millimeter or more metastasis, maybe we consider it because we know that the outcomes, right, are worse here. So it's something to think about. And also maybe those ones that have less than 0.3 and really have a great 5-year melanoma-specific survival, maybe we don't have to be PET scanning them every 6 months or every year, and we can think about that a little bit more closely. However, we know those patients also have the risk of nodal recurrence, so we do ultrasound them still, right? And that is a low-risk, low-cost way to survey our patients. So, you know, when we think about using gene expression, can that predict the sentinel lymph node involvement in high-risk disease? You know, in my patient that I just said, if it was performed, could have that prevented macroscopic nodal disease? Potentially, but we don't know. The MSLT1 data I showed you didn't test in melanoma, so we don't know if that would be the case in this case. But this, again, is a good example where we do need prospective data for a gene expression profile to help us do this, to decide when to do a sentinel lymph node biopsy in maybe the higher risk patients. So this patient, just to kind of close the loop, I did a complete nodal dissection. She had extensive disease, 5 out of 19 lymph nodes. There was extranodal extension. So she ended up with stage 3C melanoma. And we're currently just watching her because they don't want to give her immunotherapy right now, but the risk-benefit changes if she does recur. So in any case, I think we need to think about, in the setting of stage 3 adjuvant therapy, there is that benefit, but only 1/5 of patients actually benefit, right? So if you look at, this is all comers stage 3, 43% don't recur naturally. Their own immune system works, or maybe the disease hasn't progressed, right? And then you have the percent that does recur, that you're improving the recurrence-free survival. So only a fifth of patients benefit. So, and we can't now predict who will benefit. So this is another plug of using gene expression in our clinical trials so that we can actually see if we can predict this. Because I think doing retrospective, it's not as good, and we have to include gene expression in our clinical trial design. Sentinel lymph node biopsies were also required for inclusion to the adjuvant trials with stage 2 melanoma, right? So this is all after sentinel lymph node biopsy, so something to think about. And why do a sentinel node biopsy instead of adjuvant therapy? So I'm going to take you through a little math here. 30% of our T3B, T4 patients will have a positive sentinel lymph node, right? So 6 out of your 20 patient population, just to give you something to look at. Adjuvant therapy decreases nodal recurrence by 30%. So if you don't do the sentinel lymph node biopsy, then you end up with about 20% of patients that require a complete lymph node dissection. In the setting where I'm saying if you know they would have a sentinel node biopsy, based on MSLT1, we know eventually they will get clinical nodal disease. Now, if we do the sentinel node biopsy, right, about 5% after a sentinel node biopsy will have an in-basin recurrence, even if they had a negative sentinel lymph node. The real number is somewhere around 3%. It depends on what data you use. 15% have that in-basin recurrence after a positive because we don't do complete dissection anymore. And so if you gave adjuvant therapy to these patients, you only have 5% that will actually require a complete lymph node dissection. Now, I'm not going to get into the whole discussion about do we do complete lymph node dissections in the setting of neoadjuvant therapy. There's 2 clinical trials going on right now, another one that's going to open up soon. We might not have to do dissection. We might do neoadjuvant therapy single node, but we don't have enough data to make it standard of care yet. But there's 3 trials. We have 1 open at our institution right now. But again, in the current setting, you might end up doing more complete dissections if you don't do a sentinel node. Okay. Patient selection for sentinel lymph node. If you want to think about a lot of patients don't have therapeutic benefit, can we predict? This is going to get into the Merlin trial. So you heard, I'm not going to get into many details. You heard about the design, but the thing that I want to point out is, the nice thing about being one of the investigators in the trials, I actually get to talk to the scientists, right, who kind of developed this and how they're thinking about it. And they did a lot of testing of just the gene expression with and without the pathologic clinical data, and this really worked the best. But I have to tell you, if you're going to add the thickness, we have decades of data to know if you have a thick melanoma, your risk is higher. So, the idea that you're going to get all comers in a trial in less than 5% is an interesting thought, but that was what they set, right? Their goal is, can we get less than 5%? And just to know, right, so this is the eligibility criteria. So we did not do T4s, okay, into this. And in order to be a T1A, you had to have a high risk. You had to be less than 40, greater than 2 mitoses, and lymphovascular invasion. That ended up with only 26 patients, okay, out of the 1,700. So we're not going to think about that data. We don't have enough patients to really say anything about that. But it was a successful test. At Michigan, 720 of those patients came from Michigan. I saw the data, I oversaw it. So it's really robust data. And when you look at all comers, right? It's about a 7% when you put all of those T1 to T3s. I can tell you if I have a patient who has a 3 millimeter melanoma, I'm going to do a sentinel node biopsy. I don't care what a gene expression test is, right? If you talk to most surgeons. So looking at this data, as a surgeon, the all comers, it doesn't matter. For me, it's going to be the subset. So I'm going to show you one thing that I want to bring up. And the reason why this is in here after wide excision, one of the things that we do at Michigan a lot, if I have a patient, right, who has a melanoma and has a positive, like a transected base, and I have to make decisions on that for a patient, we will microstage. And this is very important for this test, right? One of the things in the algorithm is the thickness. So if you have a 1 millimeter transected base and you put 1 millimeter into the algorithm, but the patient actually has a 2 millimeter melanoma, that's going to change the outcome. So we pushed to look at the wide excision the real depth to see if that changed the algorithm, and it did, okay? So in all comers, not a ton, right? 7.1 or 6.6, but if you want to try to get under a certain number, it does make sense. So if I'm going to use a Merlin test, I make sure that I know the absolute depth, so I ask my dermatologist to do a microstage. So this is the key patients, right? The ones where you're going to think about, do I do, the consider, the 5 to 10% consider. I spend a lot of time with those patients. It's very easy to tell a patient with a 2.5 millimeter melanoma, we're going to do sentinel node. That's what I recommend. It's very easy for the ones that are right. But this is the group. It takes a long time to have these shared decisions. If you look at the T1Bs, and especially if you have the correct thickness, a low-risk test is 4.6%, right? You're below your 5%. So this is like a win if it's going to make a difference. Now, if I talk to a patient and they want a sentinel lymph node, then we're going to do a sentinel lymph node if they fall into that, right? But if there's the patients that either don't want to go to the operating room or they have morbidities, this would be a nice utility. For the T2As, it's going to be about 8%. And for some patients, less than 8% makes sense. You have to decide that with your patient. I do want to say for head and neck melanoma, we had 284 patients. It works really well. So this is all comers. This isn't just a certain stage. When you look at all head and neck melanomas, you can get below the 5%. In patients older than 65, you're at 6.6% for the low risk. The design of this was to say who not to do, right? Forego sentinel lymph node biopsy. So we're not talking about high risk. We're talking about that. So let me just quickly, do I have time for patients? No?
You've got to get to Henson's talk.
Okay.
I think, are you over 20? I think you're
I don't have a... Okay. All right. So just really quick. So here's an example, right? Memorial MIA, we're at 12 and 10. You can see that you would be above 10%. This patient came back as an 8%, just to give you an idea. And it also can work the other way around, where I had high-risk patients where they go to the OR. So I have a lot of different things. I just want to tell you, this is the exciting thing. We can't talk about prognosis right now, but we're going to have long-term follow-up data that's really exciting, including all the adjuvant therapy patients. Okay, I'm going to just leave that there.
okay. And you're here to answer questions.
Yes, I can answer
maybe
questions.
We can I just want to be respectful of Henson's time, too. And thank you so much, Christine. Great data. So my pleasure to introduce Dr. Henson Tsao, my high school classmate. He's from MGH and Harvard. Everybody knows Henson. And he is going to talk about adjuvant and neoadjuvant therapy approaches. And then if we have more time, Christina, maybe you can come back and show those cases. But thank you.
Susan already talks fast. Man, that is a high speed there. So anyways, Susan, I didn't get the email about the dress code. Chris and Doug and everyone looks so beautiful. Michael, I'm sorry, I'm in my Marshall with Henley here. So anyway, it's going to talk about adjuvant and neoadjuvant, and it's great that Christine talked a little bit about this, and I'll sort of go through it again, because this is probably some of the more innovative and exciting areas going on now. These are my disclosures. I love making images with AI, so you'll see some of that. So you've seen variations of these curves. Basically, as you sort of stage up, the survival goes down. There are some patients with such good survival, you really don't need any therapies for them. And those are probably the vast majority of the dermatology patients, certainly. And the goal of neoadjuvant and adjuvant treatment is try to boost those patients in the higher stages back up to a good survival place. So this is a time map of all the therapies and when they've sort of come out. And here we're looking at the approvals for the adjuvant use of those therapies. As you know, most drugs start with stage 4. Events are obviously more robust, and obviously the rationale for it is much more compelling. So I'll start out, and this is the first time AI has actually created my patient Mel. It's sort of a realistic look. So I'm going to talk about several scenarios which you might come across to think about things. One, microscopic nodal disease, where you obviously can't see any nodes. High-risk stage 2 disease. Macroscopic disease, where they may have recurred after the primary excision. And finally, sort of macrosatellite in transit disease, which is quite rare. So I'm not really going to talk about that at this juncture. So let's start with microscopic disease. Here, obviously, you take that little node out with the blue dye, and you look at it pathologically, and according to the latest NCCN, if the deposit is less than 0.3, and again, Christine talked about these very minimal disease in the lymph node sort of ideas in survival, obviously observation is recommended. If it goes above 0.3 or stage 3A or B, consider imaging to make sure, again, if there's widespread disease, the idea of sort of going after stage 3 disease doesn't make sense anymore. You're looking at much more advanced nodal ultrasound in lieu of completion dissection, even though that can be done still in some settings. And then adjuvant treatment, and we heard a lot about adjuvant treatment towards the end of Dr. Angeli's conversation there. So observation is a possibility. So let's take a look at pembrolizumab as an adjuvant treatment. This is the 2024 follow-up for KEYNOTE-54. I'm just going to highlight a few things. The initial trial was about 500 pembro versus 500 placebo. Median follow-up 6.9 years. And with almost all adjuvant trials, it's relapse-free survival because basically you have no disease to track. So at the time that you develop another nodule or another mass, then you sort of exit the trial. Why? Because then you're going to get treatment. If you completed that to a melanoma-specific survival endpoint, you can't give anything until that patient sort of dies from it. So just in terms of the ethics, it's quite challenging to keep overall survival as the primary endpoint. And also, again, once you develop a recurrence, there's an entire stage 4 sort of protocol to undergo. So these are the latest curves. You see at 7-year follow-up, pembro is 50% survival, placebo 36, and a hazard ratio of 0.63. Hazard ratio is what most people look at for Kaplan-Meier. It is literally the probability of a recurrence or some event relative to placebo or the control arm. So this is 0.63. There's 63% chance of recurrence compared to not taking drug. So if you did the 100 minus that, that's the percent benefit you got getting out of the drug itself. So any hazard ratio under 1 is great. Any hazard ratio over 1 means that your drug is more toxic than it should be. So this is 0.69. If you look at the division of the 3 different types, stage 3A was not statistically significant, but 3B and 3C both were. Let's take a look at Nivo, another anti-PD-1 treatment here. This is Nivo versus Ipi. Ipi was the standard of treatment at the time due to a lot of the studies Lex Egermont did. So this is about 450 in each arm. Again, relapse-free survival, median follow-up, 60 months roughly. This is in 2023. And here are the final numbers. 5-year relapse-free survival, 50 versus 39%, with a hazard ratio of 0.72. So Nivo did better than Ipi. Overall survival, no difference between the two. So CheckMate, this is a combination examination of adjuvant stage 3 and 4, combining both CheckMate 238 and DEORTC 18071. So if you look at the numbers, they really wanted to look at this mixed cure model, which basically say when you sort of look at that Kaplan-Meier curve, there's really 2 groups. One that were cured and another that was not cured. And the little trail off on the bottom suggests that the non-curers were sort of, undergoing attrition at the time. So when looking at this, I just want to really show you the sort of hazard curves from here. Most of the events, and you see this in the Kaplan-Meier curves, there's a huge drop-off in the first 6 months to a year. Those are patients that innately are not going to respond. So that was the non-curable sort of group. So this is something to sort of think about as we start stratifying and start analyzing these patients. Are there sort of fundamental differences between these 2 groups? And if you look at it, stage 3 patients and those under 65 are most likely to benefit from adjuvant treatment. BRAF-MEK, which is probably used much less commonly these days for BRAF mutated tumors. This is a COM-BAD with a final evaluation at 2024. About 450 again, placebo versus the combination. Median follow-up 8 years, relapse-free survival. And these are the relapse-free curves. 48% on drug, 32% on placebo with a hazard ratio of 0.52. And if you look at overall survival, melanoma-specific survival, again, no difference, 8 years overall survival, no difference, melanoma-specific survival overall. One of the reasons, probably not so much what they got up front, But often after you relapse, you start getting really effective drugs. So this speaks to what Chris and Christine and a lot of people talk about. What is the point of relapse-free benefit if overall you're still going to get benefit later on if you recur? You're just treating them sort of slightly upfront. So with salvage therapy, they did pretty well. Let's look at the high-risk stage 2. These are the patients that walk into your clinic and they have this 3, 4, 5 millimeter thick tumor sitting somewhere. Currently, wide resection is still the #1 surgical sort of approach. Sentinel lymph node biopsy, if it's positive, you go down that stage 3 sort of algorithm. And what happens if you're sentinel lymph node negative? So here you have no disease. Do we give treatment to prevent the onset of disease? That would be, again, adjuvant treatment. The two are pembrolizumab. It's also okay to give XRT potentially in certain areas, or there are probably trials ongoing right now. So let's look at pembro. This is Keynote 716. This is the 2024 follow-up, looking at the stage breakdown. Very few stage 2As, mostly 2B, 2C, and that's what the actual recommendations are going to talk about. All of them were sentinel lymph node negative, and those are the numbers, about 490 in each arm. Primary endpoint, relapse-free survival. And here you are with 36 months follow-up, relapse-free, 76% survival of pembro, 63% with placebo. If you did a ratio, that's 0.62. If you divided it, which is the difference in survival, that's about 12.8%. That's the delta. And here's 2B and 2C showing you the same data. They're all roughly with a hazard ratio of about 0.5, 0.6, but you can see the deltas kind of fluctuate between 12 and 13%. One thing to remember, you have a large enough trial, and you go from 98% survival to 99%, that's a hazard ratio benefit of 0.5, right? But a statistical difference of 1% in survival. So the delta comes into play when you have really early disease to sort of think about, especially in the setting that 18% of these patients undergoing these treatments are going to have some kind of severe immune reaction overall. This is distant metastasis-free survival, 0.59. It is significant that the delta here is 9.7%. And you look at who responded, males and individuals under 65 experienced the most benefit. It's not that women don't respond necessarily, it's that their survival in general is better. So the actual benefit boost up is not statistically as robust as men who have, obviously have a poorer survival. So that sort of brought it, gave them a greater boost overall. So let's talk about Nivo versus placebo here in 2023. Checkmate 76K. This is adjuvant setting. This is a 2-to-1 trial with 526 Nivo versus 264. Intention to treat at 12 months relapse-free. 89% Nivo, 79% placebo, so a delta of 9.6 and a hazard ratio of 0.42. If you look at the separation between 2B and 2C, pretty similar overall, both statistically significant at 0.3 and 0.5 hazard ratios, each with a delta that's around 10%, a little bit less, a little bit more. This is the intent to treat distant metastasis-free survival, and here, 93% with Nivo, 86% with placebo with a delta of about 5.6. So those are the numbers with high risk, all right? Clearly some benefits with relapse-free survival. Clearly the numbers look better with the hazard ratio, a little bit sort of more real life when you look at the delta overall. And something obviously to think about, you don't that much in stage 4 for the oncologist, is the real chance of a side effect with these drugs, which can be quite obviously severe and sometimes irreversible. Let's look at macroscopic disease. There you got a little lump, say, in the lymph node. Core needle, fine needle, core biopsy or fine needle biopsy is obviously one way to go to establish the diagnosis. I've had patients who have metastatic breast cancer thinking it was melanoma because they have a mass. So, making sure the tissue in the lymph node is completely discernible and diagnosed before proceeding is obviously very critical. Imaging, as I said, there's widespread METs. It's a slightly different algorithm overall because there you're treating unresectable disease at the time. Therapeutic lymph node dissection can be done, all right, which you sort of remove things, and then you can give adjuvant at that point. You've removed disease. There's no evidence of disease. You're going down that track. The other side is the neoadjuvant approach, all right? And here, you give the drug up front, hopefully shrinking that tumor a little bit, and then you take it out to see what remains in that lymph node. And this is where I think Michael talked about how much pathological disease there is, complete cure versus partial versus, again, no response. At that point, you can give adjuvant, XRT, or observation. So what I really want to touch on in the last section is the neoadjuvant. I find that this is being used quite actively, certainly at my institution. So let's take a look at the data. Pembrolizumab, this is in 2023. Neoadjuvant plus adjuvant alone. I think this is one of the ones that really, one of the studies has sort of put this on the map. There have been smaller studies overall, but this one was really profound. 2 arms you can see, 150 roughly in each arm. One you gave Pembro every 3 weeks, 3 times only. You took the nose out and you gave it 15 more weeks. The other one, you took the nose out and you gave it a total of 18 weeks. Same amount of Pembro, just broken up by giving 3 doses up front versus the rest after surgery. So that, in essence, is just the difference between neoadjuvant and adjuvant disease. And if you look at the relapse-free survival, huge differences here, 72 versus 49%. So if you gave it up front, clearly there was a much better relapse-free survival benefit compared to adjuvant treatment. If you looked at subgroups, almost all of them did better with neoadjuvant plus adjuvant compared to that alone. Nivo plus IPI, this is in 2024, the Nadina trial came out, event-free survival. This is slightly complicated. You got this IPI and Nivo for 2 doses, and then there was a question of path response, all right? Once you took the node out, there was a major path response, not much tumor left in the node at all, nothing happened. If there's a partial or no response, then you got some kind of adjuvant treatment afterwards. DNT if you have a BRAF mutation, or Nivo for 11 cycles. The other one, again, was the control arm with surgical removal and Nivo for 12 cycles. Pretty much the same graphs. Maybe they just colored it similarly so it would remind you that these occurred, 84% versus 57% with a really significant hazard ratio. Didn't really make a difference between BRAF mutant and BRAF wild type overall. I think the critical point here is if you looked at it and stratified it based on pathological response, for those patients with a major pathological response, they didn't get any more treatment and their survival was 95%, all right? So just giving them a couple of doses, and if it completely shrank and you watched, these patients seem, at least in the interval, and that's a pretty short interval, so clearly longer-term follow-up is essential. It's really saying that you have that sort of high responsive tumor and that your survival is going to be really good. Nivo plus relatlimab, this is a trial that came out in 2025, single arm. You had the 2 agents. That's an anti-LAG3, by the way, sorry. The relatlimab, then you got the tumor out, and you had, again, the combination for 10 more cycles. This came out in 2022, and this was their initial what's called the waterfall plot. And if you look at the partial response, 60% had complete response, so that's a pathological CR. And if you look now at the follow-up at 2025, and this is stratified in terms of markers, all right? Low TIGIT, high B7. So those on the right-hand side, if you look at the major path response, they maintained pre-disease-free. Those with less than a major path response, obviously there were a lot more events. So again, they sort of, the corollary of this trial is whenever you're giving them in a neoadjuvant setting and you watch the actual mass, if it shrinks and disappears, that's a really good positive sign. Dabrafenib, trametinib, again, has been looked at in 2024. This is NeoCombi, and again, it's a single arm trial looking at giving some DNT twice a day for 12 weeks up front, removing the tumor, and then following up with 40 weeks. So survival is not the outcome here. It really is looking at the percent path response. And little less, but if you had a good path response, 53%, that was probably a combination of complete and partial. And if you had no path response whatsoever, survival was quite low. The log rank didn't really meet significance. These are small numbers. But again, echoes the theme that in the neoadjuvant setting, if you can document a robust reaction up front, generally the patients do better. And here, neither relapse-free survival or overall survival were significant if you really looked at it. So take-home messages. Adjuvant treatments are now showing significant relapse-free survival for those with stage 2B and above. Again, the conversation to have between relapse-free and overall survival is active, it's dynamic, and it's argued upon all the time. Neoadjuvant approaches are here. Again, in our institution is used quite a bit. The effect of overall survival or melanoma-specific survival is still being explored. And the question really becomes, if you treat now versus later and leads to the same outcome, then maybe there's unnecessary risks for toxicity. Sort of the idea being, and this is a thought experiment, if you can cure all melanomas and you just waited and then they developed a relapse and you gave them, they were all cured, it really wouldn't matter that you treated them up front. So it really comes down to the efficacy of that drug in the relapse setting. So biologically, if you think about it, if you gave it to them in a neoadjuvant setting and you somehow selected out resistors, then that's not a good that's not a good situation, because then you try to salvage them afterwards and they have less of a response. Or you can say, well, you gave them some drug and it tried to prime the immune system so they tend to respond better. So that kind of, post-relapse survival on the same sort of agents, that's the kind of analysis that's probably going to make or break the overall survival numbers in our approach to these things. So with that, I'll stop. Thank you very much. And again, thank you for staying so late in this meeting. Stay here.
Yeah. So let me invite the other speakers up. Someone left glasses up here. You? We all need our readers. So I know we have about 10 minutes left for questions, and I don't know if folks have a lot of questions. I know there's been a discussion about GEP in one of the other sessions just before this, or if we want Dr. Angeles to put up her 2 scenarios where she felt the Merlin test could be helpful. So a vote on questions versus new slides, or whatever we can do. Chris is gonna, Dr. Bajakian is gonna stay after when I have to leave at 4 to field additional questions. But any questions offhand? And I'll have the panel come up. No questions. One question. And Christina, maybe I can put yours up, just because I think that's super interesting. I just wanted to be sure. Yeah, go ahead.
Survival versus long-term. I know the data is not in yet, but I think of President Carter, who they thought was in remission, but I think it was after 7 years he had a recurrence. Do we have other data up to 7, 8 years on any of these studies to see what the effect is in terms of long-term survival?
You mean in the adjuvant setting? Like the overall survival in the adjuvant setting?
Yes.
Yeah, I think they're beginning to emerge. I don't know if in the latest ASCO anyone saw any of the longer-term follow-ups, but...
Yeah, well, I'll let Christina also answer. We're still waiting on the overall survival benefit, and I don't remember his initial stage of disease. If he had stage 3, I know he progressed to stage 4 and was one of the first high-profile responders to anti-PD-1 therapy in his 90s with minimal side effects, and he did not succumb to melanoma as his cause of death, to my knowledge.
I think it was a brain met too, right? Yeah. So that was
profound. But he had that sort of typical thing where we see disease recurrence despite our best efforts sometimes after even adjuvant therapy in the short term following diagnosis. But the long-term data on adjuvant therapy-related overall survival is still pending. We know it improves relapse-free survival, and it's a big discussion our oncologists will have with patients. They may say, well, look, if the neoadjuvant data is looking so favorable, maybe I'll just wait until I recur, although that can have its downsides. As Dr. Angeles has said, it could be a much higher stage disease at that time, but they may wait till they recur, and if the therapy is going to do as well then, maybe you wait. So there's a lot of discussion in terms of timing immunotherapy, but upfront right now in stage 3 is kind of standard.
Can I just ask a related question, just with therapy? We've used in the past like a 5-year survival, but based on some of the information now available, are there patients who are doing fine at 5 years, but 7, 8, 9, 10 years relapse because of some cancer cell that did not respond to that therapy and now has grown and taken over?
I think if you look at the New England Journal, this is for stage 4, the chance of survival, if you made it to 3 years, is almost 96, 97%. All right, so there probably will be trail off. My bet is that because people start dying of other causes after 10 years, it's going to be really hard to follow that. But there's clearly ultra late relapses. I had a patient just last week who had a melanoma in 1979 that relapsed this year, but those are rare events. The one thing with the really widespread disease in the stage 4s, if you make it to 3 years, which basically says the two compartment model I sort of talked about, there's the curable and non-curable, right? That's the two compartments. After 3 to 4 years, you've sort of cleared out the non-curables, and at that point, what remains, it looks like, is probably the curable group that remains. So,
Thank you, and you had some very nice presentations.
thank you.
Oh, I think the gentleman right there was,
Yeah.
right up here.
First question regarding the sentinel node biopsy. It's been dogma for as long as it's been available that ought to be done in the same setting as the wide local excision. I think last year in this in a similar forum, a respected expert refuted that and even said, you could do the sentinel node biopsy anytime later, which was really in context of a dermatologist office. We're not doing sentinel node biopsies, but we're tempted to do the wide excisions. But it's not been my practice, but I know I've practiced with people who do that. And, I want to know what your feelings are on that.
Do you want to start?
You can negate the ability to identify a sentinel node accurately via preoperative lymphoscintigraphy if you've done a wide excision, if you've oriented even a large excisional biopsy, horizontally crossing over afferent lymphatics on extremities. And that can be problematic. We can follow that patient with nodal ultrasound, which is still a very excellent way to follow these patients who are eligible for sentinel node biopsy and either don't undergo the procedure for medical reasons or the procedure isn't technically successful. But it's not optimal. Patients are unhappy. If they come to you and you say, we can try the sentinel node now, it might not work. And we typically would have done this at the time of the wider surgery. Now, there is one study looking at Mohs surgery, talking about the fact that if Mohs is done in patients who are sentinel node eligible, it can be done and not sort of disrupt that opportunity. But in that study, at least 85% of the patients underwent sentinel node biopsy first and then went to the Mohs surgeon to have those cleared. Okay, that's a different way to do it. It's asynchronous surgery. Is that valuable? We'll know down the line as we understand margin control and what the Mohs is offering. But I think ultimately, for the patient's best interest, the procedure should be done in the same operative setting to maximize the accuracy of the procedure as a pathologic staging tool. And
Yeah, I have lots of patients that they won't map after wide excision, or when, especially on the trunk or the chest, we don't know if it's going to the right place. What if it goes to one site, but maybe it should have went to two, but the lymphatics over there are cut and scarred?
Well, it certainly validates my practice. The other thing is in this whole context of neoadjuvant immunotherapies and other therapies, but just neoadjuvant, if you don't have to take out the tumor burden in the lymph node, why do you have to take out the tumor burden in the skin? In other words, is the wide local excision even necessary?
it's being studied for stage 2. I mean, it's
Right,
being studied.
it's being studied. There is a lot of thoughts about that for the high-risk patients, that just giving immunotherapy up front and then seeing if you have a complete pathologic response, whether it's in the primary or the node, right? What we want to do is train the immune system, right, to make those T cells have memory so we don't have recurrence. So this is all being studied, but it's not standard of care yet. It's in clinical trials.
I look forward to next year.
Yeah, I just want to extend that thought for a second. The idea is that you have tumor-reactive lymphocytes on site being trained while you give them immunotherapy. So, treat while the thing's still on the skin, treat while the mass is in the lymph node. And people have asked them, why not treat when you have a sentinel lymph node, microscopic disease? Would that be helpful? Then the whole idea becomes maybe we should just treat first without doing a sentinel lymph node.
That's right.
And maybe that'll give a bigger result in the end.
Well, that was the scenario I presented initially, this patient with occult disease, but high-risk primary, stage 2C, but PET CT showed something, we could identify the nodes, do the FNA, and did neoadjuvant. I think it's interesting, we've had patients who come to us not infrequently billed as a stage 2C, big bulky tumor on the skin, who then have an obvious nodal met that we can feel. We find needle aspirate it in clinic, prove it, they see the surgeon and the oncologist bypassing, again, our side of things on the front end of disease. And those patients who get neoadjuvant invariably have shrinkage of the tumor on the skin. And when it comes out, it's not nearly as, we don't generally do a 2-centimeter margin. We're kind of saying, let's just get it out now with a centimeter margin. A lot of the time it's just necrotic tissue, no viable melanocytes. So does that have the same prognostic significance as the node as we now know with the major pathologic response. But it's coming. It's going to be studied in injectables with an RP1 or RP2 agent in the skin for stage 2 disease. And so I think it's an exciting time. We may reduce surgery overall. Sorry.
Thank you.
Yeah, no, I think this is really exciting.
I'm going to step out, but please keep going. And I want to thank everyone. And Chris, do you mind taking over the panel moderation?
We're at time, are you sure?
If you guys are okay, just a couple more questions.
Yep.
Yeah, sure.
I just started using the GEP testing, but I'm only using it in kind of one place. I found the sentinel lymph nodes to be unreliable on the head and neck.
Yeah.
So I've only been using it in that population, tumor stage T1A with the base positive up to 3s, just because I find it unreliable. I've had a lot of recurrences even with negative sentinel nodes. So I don't know what your thought is on that, particularly head and neck. And I haven't seen anybody specifically looking at that population with the GEPs. So I just want to know your thoughts and your take on that approach.
Yeah, so when I first talked about sentinel lymph node and I gave that 98% sensitivity, that's in, all comers. But if you look at just head and neck, that goes down to about 85%. So there are a lot of head and neck sentinel lymph nodes that are missed for that, just because of the mapping, et cetera, et cetera. So that is one area that, we've been thinking about the results of the Merlin test, because in head and neck melanoma, they were actually better than sentinel lymph node in many, when they looked retrospectively at some of the published data for head and neck, that they could pick out the low risk and high risk a little bit better. So that is something that I think could be very useful. I think whenever we think about using the GEP test, though, it's a discussion with the patient, because there's still a risk, right? It's not like you can say there's zero risk it's being there, and if it's a high risk, and even in the setting of high risk, it's not 100%, right? So I think in that, but I do think there's going to be more clinical utility right now, especially with the Merlin test with head and neck and the older patients and the T1Bs specifically. Yeah, I can go through this. I know it's that time, you guys can leave, but I just, when we use this in the test, the NCCN guidelines say that you refer to the surgical oncologist, and we use the Merlin test as how to make a decision. So, this particular patient that I had was, a lot of comorbidities, high risk, on Eliquis, had a mid-back. So this is those patients that can map to 4 different areas. So the surgical risk goes up in a patient like this. And I used the nomograms, and we had, 12% risk in the Memorial. The MIA was about a 10% risk. So that hits above the 10% risk. And I said to him, but he's above 65, and the morbidity would be higher. So, when you think about what the Merlin test is for a T2A, a low risk would be about 8%. And I said that to him. I said, and I feel good about this data, so would an 8% risk make him feel okay not taking the morbidity of surgery? And then when you look at just all comers greater than 65, that becomes, even lower. So, but I told him 8%, and then when I sent it, it came back as low risk, right, and 8%. And he decided to do wide local excision alone. He understands an 8% risk, right? And then we discuss full skin checks, neural exam, and I tell the patients, maybe you do fall into that, right, 8%. Maybe you do have a positive sentinel lymph node. If we pick it up and we identify it, we have good treatments in our toolbox, where I can tell you, when I was in training, or even 10 years ago, we didn't have good, right? And I think this is one of the things with surgeons. We wanted to do more and more surgery because if we lost control, we had no good therapies. Today, we do. You just heard about them. So I think we have to think about being a little bit more mindful when we treat patients. Here's another patient, 65, COPD, just had an MI a few years ago, didn't look like a good surgical candidate, but we could get him through, could be okay. Left arm, 1.3, no ulceration. I was like, okay, so this is a lower risk, but still by the nomograms, 8 and 9%. I said, okay, so you're less than 10%. But I sent, thinking about, this again, it came back as 19%, right? So in this case, I said, well, you know what, maybe we should do it, and it was positive. So it's still, he falls into the 3A. So we said a good 3A. I don't have it was less than 0.3, so he's actually, right, better if you think about that lymph node amount. But we're surveying him, right? With the other patient, we're not surveying. This one we're surveying with ultrasound, PET scan yearly, et cetera, et cetera. So just to give you an idea, and this is not all, I don't use it on all my patients. I use it on the patients when we have the discussion, because I have some patients that are like, no, I'm more than 5%, I want to be in the operating room, then the Merlin test isn't going to help me with those patients, right? It's the ones that don't really want to take the risk of anesthesia going to the operating room. They don't want the potential morbidity, et cetera, et cetera. So it's a tool that we use. Now, as time goes on and we get the longer term follow-up data, this is what I said. So we have the numbers from like sentinel lymph node biopsy, positive, negative in different groups, but we're going to look at all these other things, right? Recurrence, for negative sentinel lymph node recurrence. We're going to look at adjuvant therapies because, we have 1,700 patients. A lot of those patients did or did not get adjuvant therapy. We have all that data that we're following, and we'll be able to see survival. So prospectively following all these patients, we're going to really be able to see that data in the coming years. So we're really excited about that. Also, we're following them. So definitely, we have 720 patients. Not all of them were positive, but the ones that then were followed and then recurred and got neoadjuvant therapy, all of this data is being collected. So I think it's going to be exciting what we see in the future. And I just think that we have to think, I said it before, but any clinical trials that we do, we really have to think about building this into that so we can prospectively see if we're picking up that high risk, low risk. Because the Merlin was designed to forego sentinel lymph node, but now let's think about that high risk. Can we pull out the high risk patients? And that's something we can do. And I think we're going to get a lot of those T1As with the Iceman trial too, which is going to be able to inform that population. That's also hard. How do you really identify that high risk population? The last thing I'm going to end with in terms of nomograms versus the Merlin trial, there was an abstract presented at the European Society of Surgical Oncology last year where they looked at the T1Bs, T2As in the in terms of, where is the benefit of using the CPGEP, the Merlin test, versus nomograms. And sentinel lymph node biopsy is the best way to pick up less than 5%, right? Nomograms don't do it. Merlin test doesn't do it. Nothing does it, okay? If a patient, you want to know the 5% cutoff, you have to do a sentinel lymph node biopsy. But if you're okay with that 6 to 7% as your cutoff, the Merlin test does do better than all the nomograms, right, in the T1B, T2As, if you're okay with that number. And so that's something that we have to discuss, and you have to discuss with your patient.
One quick question for you.
Yeah.
And by the way, hi. What if you just did nodal ultrasounds?
Yeah,
And
that's
just
interesting.
every 3 months and just skip all this stuff.
Yeah. So,
and then you just do something when it comes up.
So this is what I want to tell you. In the state of Michigan, we see a lot of the melanoma patients, and a lot of my patients who get nodal ultrasounds, they live 2 and 3 hours away. They don't want to drive to see me.
Okay.
So I try to get them to do it local. They can't do it.
Okay, so
Training ultrasonographers to do that nuance, they have to be high volume and they have to know how to do it. I actually can't get our community hospitals and other hospitals to do it successfully. And if you don't do it well, you're going to miss.
okay.
So that's the current thing. I mean, if we could get, and I think a lot of radiology departments just don't have, like we had to hire a lot of ultrasonographers with our volume.
Okay.
Yeah. All right.
All right.
Thanks.
Thank you all for staying. It's been a pleasure having you all here. Safe travels to where you're from. Thank you.
No, not at all. I could get you to lecture. Maybe even by Zoom. We have a melanoma lecture series then. Because I think the way you sort of spelled out Merlin, first of all, you have experience. I don't think we've ever used it yet.
Yeah.
Just to understand where it's helpful or not.
Yeah.
You know,
I had a lot more other examples, but I tried to just do 2 that was there.
Did they not?
Javier, Cantonal.
Yeah, they don't use it. Yeah,
They
John,
don't
we have
use
an
it.
IO buddies.
Yes, I don't
She
think
and I
they
are
use
real
it.
good
'Cause I've
buddies.
never
No,
seen.
No, they don't.
They weren't, and they were not part of the trial.
No.
Intentionally.
There was only so many places that they could do it, and they tried to diversify throughout the country. So.
But doesn't mean we shouldn't do it. It just
That's
means
what
we
I'm
don't
asking.
have the
How do you
evidence.
Order it, but I mean, Pat sends it, right? I mean, you put in the
Oh,
order.
anyone could order it.
So in
You just
Epic,
have
you
to
just
have-
go.
Oh, no,
it doesn't work that
It's
way.
kind of like Tempest.
Okay.
Do you know Tempest?
We don't, we,
Yeah,
okay.
so in oncology, like, it's not, you have to, like, fill out a form. and
I see,
fax it.
okay.
They would, oh, sorry.